So I'd like to introduce our speakers today. We have with us Teresa Devitt Lynch. She has a master's degree in nursing and is board certified as in advanced forensic nursing. And she also certified as a SANE A. As a U.S. military veteran, she served 20 years in the Navy Nurse Corps, where she worked in diverse healthcare settings, including med-surg, ambulatory care, couplet care, as well as education and training. The last 7 years of her service were dedicated to forensic nursing and caring for military members and their families who were impacted by sexual assault and intimate personal violence. While on active duty, she was a tri-service sexual assault medical forensic examiner trainer and expert forensic nursing consultant for military courts, martials, proceedings, in all military branches. She also served as a lead forensic examiner at the Naval Medical Center in Portsmouth, Virginia, and the Sexual Assault Medical Forensic Examination Program Director at the U.S. Naval Hospital in Sigonella, IT. She is at Italy. Okay, Italy. She has steadily been engaged in organization, national, and community-based initiatives aimed at fostering multidisciplinary collaboration and improving forensic healthcare in response to violent trauma, and is currently a member of the Academy of Forensic Nursing Board of Directors. Our second presenter today is Andrea Ward Wiley. She has over 10 years of experience in forensic nursing in both the private sector and in the military. Her non-forensic nursing experience includes staff nursing and leadership positions in rehabilitation and long-term care, postpartum, complicated OB-GYN surgical recovery, ambulatory care, triage, immunizations, and referral management. Andrea is currently the owner of Cardinal Forensic Healthcare and recently moved back to the States from living overseas in Japan. Prior to moving overseas, Andrea was a forensic nurse in Northern Nevada and a clinical triage nurse at Naval Branch Health Clinic, Naval Air Station in Fallon, Nevada, and provided training and support to multidisciplinary teams aboard the air station. Andrea began her career in the military as an officer in the Navy Nurse Corps. She served as the lead examiner for the SAFE team at Naval Medical Center Portsmouth, where she trained and precepted forensic examiners and provided training and support to different multidisciplinary teams. Andrea deployed to the Joint Task Force, Joint Medical Group in Guantanamo Bay, Cuba, where she provided detainee healthcare and provided on-call services to Naval Hospital, Guantanamo Bay. After Andrea received her honorable discharge from the Navy, she worked as the sexual assault medical response coordinator for the Air Force Medicine at AFMSA. She coordinated and provided resources, training, communication, standardization, and sustainability of the Air Force's sexual assault medical response programs in stateside, overseas, and deployed locations. While working with Air Force Medical Support Agency, she was also an on-call forensic nurse examiner in Northern Virginia. She holds a bachelor's of science in nursing, a master's of science in pharmaceutical science with a concentration in forensic science, and a graduate certificate in forensic death investigation. She's a current member of both IAFN and the Academy of Forensic Nursing and is involved as a leader in many military support organizations. And on behalf of all of us, we would like to say thank you for your service. Let's go ahead and do the poll really quick before you get started. As a panelist, you are able to vote. So we have two questions for you. Do you currently care for military patients? And it is a select all that apply. And we'd also like to know what region of the country you are in. So we're sitting at about 80% of our persons voting. So I'll go ahead and share that screen. And it looks like about half of the persons on board today have not cared for military patients. Otherwise, we do have a nice blend of people who've cared for active duty veterans and military family. And about 60% of you are from the East Coast, the rest from Central, Mountain, and Pacific. And I'm from Alaska, just have to say that. We've got a nice smattering for people today. So I'll go ahead and close that poll and turn it completely over to you.
All right, thank you. I'm going to get started. My allergies are acting up, so I might have to clear my eye every now and then. But I'm Teresa Devitt Lynch. This is the Military Patients 101, what forensic nurses need to know. I am going to try to get my PowerPoint to go forward. Okay, so this is what we're going to cover today. We're going to talk about military culture and structure. I'll cover that section, and then Andrea is going to discuss the incidence of sexual assault, barriers to reporting, and the role of the SAPR office in responding to adult sexual trauma in the military. And then we will finish it up with a discussion of the military versus civilian court systems. So, you know, the military culture is very unique. Even outside of our U.S. culture. It, you know, it's based on traditions and beliefs that bring together people from other cultures. It unifies us to accomplish a mission. The military is very mission driven. And, you know, since having this military experience, not only is it a subculture of the U.S., but it can be very unique as each person brings with them their foundational values and cultures and incorporates the military life into that. So military patients bring with them not only a foundation in the military life, the military culture, but also other cultural and individual aspects too. And so for some healthcare providers, this can be a very complex patient population. And really the gap between the civilian world and the military world started after Vietnam, when they got rid of the draft military and turned it into an all volunteer military. And since then, only about 0.5% of the US population has actually served in the military in some form or fashion in their lifetime. In terms of active duty and reserve, we'll go through what those components are individually, but collectively, there's just shy of 3 million active duty and reserve components. There's a few more active duty than there are reserve. And then at any given time, there's about approximately 22 million military vets in the US. And even though they may not actively be serving in the military, they still carry with them the foundational elements of the military culture that really became enmeshed into their own lives. So they carry that with them to some degree, even after they are discharged or you know, resign from the military. So that's something to keep in mind when we talk about military patients. Not only are we talking about active duty, but we're talking about active duty, reserve components, family members, and then veterans too. So the military culture is it's unique in the sense that it is founded on it's defined by its mission. Everything starts with and ends with a mission and mission accomplishment. And this trickles down from the president, who is the commander in chief of all of the armed forces. And then you've got the Secretary of the Army, Secretary of the Navy, Secretary of the Air Force. And those are the three branches or the three departments of military service. And so the Army, the Department of the Army, has the United States Army. The Department of the Air Force includes the Space Force and the United States Air Force. And then the Department of the Navy encompasses the Navy and the Marine Corps, and then the Coast Guard when we're under conflict. The Coast Guard, when we're not under conflict, they fall under the Department of Homeland Security. Now, even though the missions might be slightly different and the values it might be slightly different, but it's all still kind of similar under that umbrella of, you know, military culture. But I can tell you firsthand, each service has their own lingo. I can spend you know, time with Air Force people and Army people, and even me as a Navy person, I don't know what they're talking about half the time because they have their own acronyms and lingo, and the Navy has their own. So not only is the military culture, but then you break it down into each of the branches, and they're also their own subculture. But you can still break it down even further So if you're talking, let's take, Navy medical hospitalmen or corpsmen. So they can serve in one of three places. They can go blue side, which is on ships and or in submarines. And even those two are separate cultures in and of themselves. They can serve with the Marines, and that's called the green side. And then they adopt the Marine culture alongside of the Navy culture with them, or they can serve mainly in stateside or landlocked medical facilities. So even within the own branches, there are still subcultures that influence how military persons behave and how they perceive things and get through life, really. So let's start with the Army. I'm just going to talk briefly about each of them. So they're the main ground force. Their primary function is to protect and defend country on the ground. They are the largest service. They're also the first service to have been created by the Continental Congress in 1775. And so they essentially go in with tanks and armor and artillery and other tactical weapons and fight the ground forces or the ground conflicts. And then you've got the Marines, and like I said earlier, the Marines are actually part of the Navy, and they specialize in amphibious operations. These are a lot of the times the first in, possibly the first out. They kind of clear the way for everybody else to come in and perform their mission during conflict. And so they're mainly focused on assault, capture, and then clearing a route for other services to attack, either on air, land, or sea. They were also, or they were organized in 1775. And again, like I said, they fall under the Department of the Navy. Then we've got the Coast Guard. This is really the smallest branch, and it started in 1790. It was first called the Revenue Cutter Service. It stayed that way until 1967, when it was reformed and renamed as the U.S. Coast Guard, and then put under the Department of Transportation. And then in 2002, because the world is changing and our military adapts to the needs of the country at the time. So it has since been placed under the Department of Homeland Security, and its primary mission in that area is to, protect the ports, protect what's coming in and going out through those ports, and our offshore and sea around the U.S. interests as well. Now, during times of conflict, they can actually provide additional military support, and then they fall under the Department of Navy, and they start to, their mission shifts a little bit from just controlling the borders and watching the borders, but then also to engaging in whatever conflict. Let's see, okay. And then we have the Air Force. And the Air Force is actually one of the smaller units. It's not as small as the Coast Guard. This was until 1947, the Air Force was part of the Army Corps. And then after the World Wars, we realized, again, changing with the needs of the country, that more air power and air attack capabilities were needed. And so then from 1947 on, the Air Force has been its own department of the military. And so it now also incorporates the Space Force. And the Air Force primary mission is to defend us in the air, and then also to monitor military satellites, GPS systems, missiles and weapons, traveling from our deployment to others. And then under the Air Force is the U.S. Space Force. And this was actually first organized. I found this interesting when I was looking at this up. This is actually first organized in 1928 under the Department of the Air Force. And its mission is space operations, just like it sounds. And it kind of remained there with, tucked inside of the Air Force until December of 2019, when Trump actually made this, it redesignated it as an actual service. So now instead of 5 branches, we have 6 branches of military service, and this one falls underneath the Air Force. And then we have the Navy, not to be biased, but the best. So the Navy was also developed, or was also formed in 1775 by the Continental Congress. And you know, just as the Army protects the ground forces, the Navy protects the waters and the sea interests of the U.S. and our allies. And then we also can provide additional air support and air attack capabilities to augment the Air Force, because we have planes as well. And again, as I mentioned, the Marine Corps falls underneath the Department of the Navy. So for the Marine Corps, because they have probably the most finite mission of all of the services, so not all of their the jobs or the tasks required by that corps to keep them moving are actually performed by the Marines. So a lot of their administrative issues, their logistical issues, transportation, meal service, and healthcare service are all provided by the Navy. All right, so then we have active duty and enlisted. So, whoops, sorry about that. All right, so the active duty, these are the full-time service members. They wear the uniform, 24/7. They are on call 24/7, and they essentially can be stationed anywhere worldwide, and are generally transfer every 3 to 5 years. And not only is the service member uprooted every 3 to 5 years, so is their family. So when you're talking about military patients and the military family, caring for them as well, knowing how long they've been in this area and the support system that they have is essential too, because that family has to start over every 3 to 5 years everywhere they go, reestablish a support system, just like the service member does. And for the most part, they live either on or near military bases, which are really self-contained little cities. A lot of them, most of them have grocery centers, the commissary, they have shopping centers, base housing, theaters, car repair services, almost anything that you could want. So when you look at the younger persons, maybe those that don't have their own vehicle, or families that are limited on transportation, a lot of the times, depending on where they're stationed, they can really live and function on base without having to venture outside, which really just further ingrains that military life into them. And then you have the reserve. And the reserve actually is the reserves and the National Guard. So each component, the Army, Navy, Coast Guard, Marines, and Air Force, all have a reserve component. And the Space Force, I don't know, because they have less than 10,000 members anyway, and it's fairly newly organized. I don't know that they have a reserve component yet. And then there's the National Guard. So the reserves, these are Federal Reserve forces that they augment the active duty services when needed, usually during conflict. And then they serve part-time. They're not full-time. So they generally, it's, a weekend a month, a couple weeks a year. And most of their jobs during that time is training for war. Actually, at any given moment, an active duty service member's job is war. And if they're not at war or in a conflict, then they're preparing for that. And that'll kind of come, you'll see kind of the significance of that when we get into more of the culture and the ethos of the military. But they serve part-time, so they're not fully immersed into that military lifestyle. So they have to balance their civilian and military life. And so that in itself can pose different challenges than what you could see with the active duty. And then the National Guard, which falls under the Army, they're federal in terms of the funding, but the actual deployment and control and organization is by state, and they usually get deployed by the government or by the governor of a state for domestic issues, natural disasters or emergencies. They can, if needed, be stationed overseas or go into conflict, but usually they go to the reserves before they go to the National Guard. So the military, each service is a little bit different, but there's 9 enlisted ranks, and the enlisted are the backbone of the military. They're the ones that keep the day-to-day operations going. They're the ones that are out patrolling, the fence line, preparing the meals. What else? Lost my cooking the meals. They're the ones on the front lines and fixing the equipment. So like I said, they're the ones that really keep the military moving. Now, enlisted, the minimum qualification is a high school degree. A lot of enlisted persons do have higher degrees, but it's not required. And then the further up the chain of command that you go, the more rank that you make, the more pay, first of all, but then also the more authority and the more responsibility. And as you move up, you increasingly become responsible for or in charge of varying numbers of subordinates depending upon where you're stationed. Whoops, not done with that one yet. So if you look here, about 50% are less than 22 years, are less than 22 years old, and then about 22% are between 26 and 30. And this really comprises the majority of the E1 to the E3 ranks. Now, if you look at the average age of the majority of sexual assault victims, domestic violence victims, they fall right into these age categories. So a lot of your patients, when it comes to military, if they're active duty or even reserve, are going to be the very junior enlisted, just starting out. They may have just left their home. They might have limited resources or sources of support, and yet they make up the largest amount of those that report sexual assaults in the military. All right, and then you have the officers, and these are the leaders. They comprise about 15%. Doggone it. Keeps moving forward. They comprise about 15% of the military, and these do not enlist. They are actually commissioned by, and their authority derives from an appointment from the President of the United States, which is then approved by Congress. And so every time we move up in rank, in the officer ranks, then we're being promoted by the president and accepted by Congress. And these are the leaders of the commands and the units. These are the ones that have the ultimate authority and the ultimate responsibility for the troops below them. So just like I mentioned, military, it's a lifestyle. So when you are a department head, a division officer, a leading middle manager, supervisor, you're not responsible for your subordinates during the workday as you would be with a civilian job, but you're responsible for their actions 24/7. So if they get caught shoplifting, then you would find out about it. You'd have to get involved. If they do, other petty crimes or misconducts, then it's the chain of command that helps to correct that behavior. And the more severe the penalty, the more severe the actions, the further up the chain it can go. They're the ones that are responsible for planning, directing, coordinating the mission and how it's going to be accomplished. And they're also, the leaders, and they're responsible for not only following the orders of those above them, but then at their level, the orders that they're able to put out, then those orders travel to the enlisted and their subordinates, and they carry those out. Now, again, 01 to 03, again, this is going to be your younger age. So, a lot of these are in the 25 age range or younger. And it's the 01 to 03 ranks that also have 7 times more likely to be sexually assaulted than the senior officer ranks. So again, you have the junior persons within the officer community. Now, another thing to keep in mind is that nurses in the military are active duty, or I'm sorry, the ones that are active duty are officers. So, the enlisted, when they get indoctrinated into military life, they learn the distinct difference between the enlisted and the officers. And any officer, any higher ranking person they're expected to be respected, and to be addressed properly at all times. And so what you might find with some of the junior people, they may feel uncomfortable with you. So I know when I was active duty and doing these examinations, I know Andrew did too, because we worked the same in Portsmouth together for a while. But I would not wear my military uniform. I would just wear scrubs with nothing that showed my rank on it, because I didn't want my rank to be a deterrent for the junior enlisted or the junior officers to really tell me the trauma that they have gone through, and to open up and be able to trust me as a healthcare provider. I also, didn't tell them my rank. I would just tell them my first name. All right, the chain of command. This is probably the most salient feature of the military culture, and it is something that is driven into military members from the first to the very last day of their commitment. It is essential. It clearly defines individual roles and responsibilities, expected behaviors. It identifies each person's position within the military, within their unit. It defines the authority that they have. It defines the responsibilities and over whom they are, for whom they are responsible. It also establishes a flow of communication and decision making. So essentially, decisions are going to be made by the officers, usually at the higher levels, but they can solicit information from the subordinates. Also, orders only travel down the chain of command, and those that are receiving the orders are expected to follow those orders and carry them out. And then if they need clarification or want to provide information, the communication flows both ways. It's just the orders that flow down. And then also one of the things that is it's also very imperative for, smooth functioning of a unit and mission accomplishment is to not jump the chain of command. And that's generally something that is forbidden. So let's say my my division officers, my immediate subordinate, and they were the one that sexually assaulted me. Well, and ideally, they would be the one I would take that problem to, but in this case, they are the problem. And so this would be one of those few exceptions where jumping the chain of command is acceptable, when the supervisor is involved in that way. And this also, the chain of command also functions as to help establish a sense of trust within the unit, a trust that the senior leaders are going to have the greater good in mind, trust that the mission is necessary, and trust that the subordinates will obey the orders that they are given and follow the orders that they are given. All right, core values. So core values, each branch of the military has their own core values, but essentially they are fundamental beliefs and guidelines that help to guide behavior, thought processes, decision-making processes. Again, not only in the military environment at work, but also in their daily lives as well. So they're expected to follow those guiding principles or those core values on a daily basis. And here you see that each of the cores, they're a little bit different. And essentially they're based upon what is the purpose of that branch? What is the mission of that branch, and what values is going to best provide a foundation for their actions moving forward and mission accomplishment? So they help to build the character of the military person, and they also help to increase morale and welfare, and to establish a foundation of unity. All right, and then you have the military ethos. This is also referred to as the warrior ethos. And essentially what this is, it's the specific training that military members receive in preparation for combat. So I said earlier, military members are either actively engaged in combat or training for combat. Pretty much that's their life. And so, the responsibilities of loyalty and stoicism, excellence, courage, and selflessness, these are the foundations of the warrior ethos, and they also guide the thinking and the thought processes and the actions of the military members, especially when you consider, if a healthcare issue comes up, if a traumatic issue, a violent assault, a physical assault, or a sexual assault, they kind of look at that as how does that impact my ability to complete my mission? Because that's what I'm there for. I'm there to do a mission. And so whatever I do has to readily make me ready to be able to fulfill my mission. And so a lot of the times these concepts too can actually, they serve to help strengthen the warrior, but they can also act as a deterrent when making health decisions and seeking help. We'll go through each one of them in a few slides. And then you have the military culture itself. And so this is the sum of all the knowledge, the morals, the customs, the traditions that are acquired by service members and their families to serve as, to gain membership into the organization, and then to help the organization to thrive and again, accomplish its mission. So, the culture really, the unit's goal is always ahead of the personal goal. Why is our unit here? What do we need to accomplish? And so, the military, military culture, people get really emotionally invested into the group or the unit accomplishment, mission accomplishment, their own personal responsibilities toward the mission. Everything is mission driven. And then you've got stoicism. This is controlling your emotions to help prepare you for challenging events that could happen during, a conflict. And then, the commander has authority over almost all aspects of the service members' lives. And this will come in to kind of keep this in mind, because I'm going to discuss this later in the court-martial section. And really, it's the community that the military culture develops. It is ingrained into military personnel. So it is the learning of the history of the service that they entered, their customs, their tradition, their language, their expectations, their ethos, their core values. That is ingrained into persons the day one they enter boot camp or officer indoctrination school. And really, you continue to learn that and engage in and display the military culture and core values throughout your military service. And really, those that are not able to conform to the military culture or absorb the military culture tend to have the most problems, may tend to get into trouble more than others do, and usually get out sooner, either of their own accord or being discharged when they didn't want to be discharged. Now, when you throw sexual assault into the mix, or even physical assault, domestic violence, this violates the core values and ethics of the military. And psychologically, the effects can be heightened or compiled when the perpetrator is in the chain of command, like I mentioned earlier, or even in the same commander unit. If it's somebody that they work with day in, day out, they live on the same ship with them, then they sleep in a very, within proximity of them. These can all be weighing factors in trying to decide on what to do. And then, I talked about the military, the warrior ethos, and this can actually, when you're talking about, physical or sexual violence and their decision-making and care, seeking activities, this can really play into that and function as a double sword. So when preparing the selflessness, when you placing the welfare of others above your own, so not seeking help because their personal health is not a priority, and them being out of work, out of commission, can impact the mission accomplishment. When you talk about loyalty, commitment to the mission, commitment to their fellow service members. So this can kind of conflict when sexual assault or physical assault is thrown in, because then they feel betrayed And yet they still have the loyalty to the mission accomplishment, but now they've been betrayed by those that are supposed to have been loyal to them. Stoicism. This can be one of the larger deterrents. This is developing that toughness to get through hardships without complaining. Suck it up and move on, or suck it up, buttercup, is what we would say. And, again, this could lead to them minimizing the effects of the trauma and not seeking because they think that their suffering, it's not as important as the mission is. And again, they just need to suck it up and move on. And so they may not get seen. And then the moral code. So, the ethos and the core values, they help service members develop and put to use that moral compass. And in sexual assault or physical assault, then again, they're feeling frustrated or betrayed when others fail to follow that moral code that everybody is subscribed to. And then excellence being the best and most effective. So, this is where they start feeling ashamed. They should have been strong enough to fight them off. Or, why did I let myself get into this situation? Why did I do this? This kind of goes along with the denial and the minimizing and the self-blame that a lot of victims feel. And then you also have the gender stereotypes, primarily geared towards women. And this is when the women feel the need to work harder than their male counterparts. They might lack a social support. You might have only one or two females. If you have a small unit, you might have only one or two females. You're on an isolated island. It's a very small, support system possibly for you. They could be isolated if they are deployed or on a ship. They'd be isolated from family and family separation. And also women, in general, are at higher risk for experiencing sexual assault. All right, so then when you get to the healthcare cultural competence, really, the goal is to provide the best care for the patients that you have in front of you. And, acknowledging that the culture impacts the initiation, attitudes towards, and the perception of the care that is offered to them. So using that effectively to help tailor your forensic practice based upon an understanding and appreciation of the military culture. Making sure that the service members and family members and veterans feel understood and feel respected. Those are probably the most common complaint or concern that they have, is that by civilian practitioners that do not have military experience or don't understand the military, they feel misunderstood, they feel disrespected, and so then that can limit their participation in their care and their health seeking behaviors. And then it can also help you readily identify and address in the issues. Now, some things that can actually, hinder the therapeutic relationship between a military patient includes attitudes, making assumptions, inflexibility, and customer service. You don't want to make assumptions. You don't want to compare military to what you've seen in movies. You don't want to ask them about it. Ask them. Most of them will tell you what they do in the military. They'll tell you what it's really like instead of you trying to decipher it based on the movies that you've seen, and then making assumptions about their military experience. Like I said, every person's military experience is different, so don't assume that they, if they went to combat, then they automatically have PTSD. If they are a female, then then they automatically feel less than. You don't ever want to make assumptions. Again, you want to base those on the individual itself. Inflexibility, having very rigid treatment protocols, not personalizing the treatment plan, or not, finding a support person if they don't have one readily with them. Your attitude, very paternalistic, condescending, judgmental. Again, this would certainly turn off any patient, but because they're in the military, they may not really address it directly, and they would just go with it and then not return for follow-up care. Customer service, lacking understanding of the military and not asking questions. I guarantee you they would much prefer you ask them questions about the military than try to guess or to just breeze over it. And then using the wrong title. So you want to, find out what their title is and what they want to be called. Do they want to be called by their rank and rate, or do they want to be called by their first name? So here's just some 3 areas that you can, look into to help develop cultural competence. So, screen, ask them, like I mentioned, ask them if they were in the military, if their family was in the military. What do they do? Are they officer? Are they enlisted? Show interest in them. You can certainly tell them that you appreciate their service, and then ask more about it. And that will help to let them know that they're being engaged into the care that they're being given. Learn some of the language, learn some of the lingo if you can. Again, this will foster an inclusiveness and a better working relationship. And then identify the existing support services and resources. So what is military specific? Are there any specific veteran programs that you can look to? Are there any specific, military family programs in your area? What are the law enforcement agencies like, and so on and so forth? And then just seeking to understand. So, again, asking about them, attending trainings like this to try to get a basic foundation of what the military population is, can help you to identify and better address their needs. And then ultimately, the ultimate goal is to provide individualized trauma-informed care, but also the care that they need and care that will keep them coming back for follow-up. All right, so that is my section. Andrea's next, but I believe we have that one last polling question.
So if you all could please add to the chat, the question is, what prompted you to attend this webinar? So we'd like to know what prompted you to attend the military focused webinar. So just put your answer in the chat if you would. It looks like the answers include, sorry, it keeps moving. People were curious. One person said she was also in the military and her dissertation was about military sexual trauma and wanted to see what the presenters had to say. We wanted to get any additional information since we have an MOU with the military. Curious about how it compares to our military practice information. Interesting topic, improve my knowledge. I testify as an expert witness on numerous cases, so I wanted to add to my knowledge. There are initiatives in my state to address sexual assaults that have occurred and been buried within our National Guard. Wanting a better understanding on how to care for military patients. I was in the Air Force, it piqued my interest. In case I have a military assault victim, I want a better understanding of their situation. I live close to several VA hospitals and would like to provide better care for veteran patients and their families. Most of the desire to learn more. I wanted to learn more. We serve 3 different military installations within a couple of hours. Would like to make sure we are treating them appropriately. I wanted a refresher for victim assistance. Always interested in improving care and outreach to assist military patients and families. Looking to see what information provided to civilians providing care to military members. We just started working with a naval hospital last year, and that was it.
Okay, great. Thank you all so much for your responses. It's great to see the participation today. Just a little bit dive into me personally with my background, just so you know where I'm coming from. I was an active duty nurse. My husband's currently active duty. I've worked as a government service nurse. I've also worked as a contractor, and I've also worked treating patients, DoD patients at facilities where I wasn't employed by the government. So I kind of have kind of a full spectrum. I'm also a patient of the military health system for the past 10 years. So it's just really important to me that patients are receiving the best care that they can, no matter where they are in the world. Like I said, we just came from Japan. So we were stationed at a Marine Corps base there. And so sometimes things are difficult when you're in more remote locations. Even though everyone knows about Reno, Nevada, I saw Debbie was on the participants. I worked with her. Fallon, Nevada was an air station about an hour east of Reno, and that could be sort of rural for a lot of medical care that patients might need, and traveling an hour for services sometimes is a barrier. So starting with the incidence of sexual assault in the military. So the number of reports of sexual assault, this number is for last year, and it's the incidents that occurred during military service. It's not necessarily ones that occurred last year, but the patients decided to report last year that this happened during their military service. And then the survey extrapolates that number. And as we know, a lot of patients do not report, and they estimate that there were 20,500 victims of sexual assault in the past year within the military system. And it breaks it down there and shows the different reporting on different percentages. Next slide, please. Teresa, next slide, please. Thank you. So Teresa dove into the military culture, and that kind of helps you understand some of the barriers that we have to reporting in the military. I'll try to do some civilian comparisons to kind of drive the point home a little bit. So with confidentiality breaches, patients are worried because sometimes the sexual assault can occur within their small, tight-knit command, and they're worried that everyone's going to know about it. When you're with a command, you train with that command, you eat with that command, you're showering with your peers, and you're sleeping in a barracks room, maybe not all one room, but in the same building. So, if you're in the civilian world, your CEO is not, if you decide to report a sexual assault, they're not going to know about it. You're not going to go potentially see who it was in the big cafeteria that you eat at. You're not going to run into them walking into your apartment building potentially. So it's just a different dynamic that can be a barrier to reporting care. For the unhealthy command climate, so sometimes these commands can be very intense and unhealthy, related to harassment, hazing, retaliation. It can be physically unsafe, or there can be, by physical, I just mean things in the work environment, not person-to-person physical, that people have brought up and they're not addressed. And so this further prevents people wanting to come forward because they don't care about them on a normal day. So why would they care about them on their worst day? As for retaliation, which I mentioned above, a patient's worried, if they report someone in their command, that maybe the command's going to take the side of the suspect or the assailant, and then retaliate against them regarding promotions or their evaluations, or maybe different assignments or duties, give them harder ones. Punishment for collateral offenses. This one comes up a lot because, as we know, a lot of sexual assaults involves drugs and alcohol, specifically alcohol, especially within the military. And so if the patient was underage drinking or using a recreational drug, the patient may worry that they could be punished for those offenses. And so then that's what we call a collateral offense. So they're worried about how that's going to affect their career and their life. So who they can report to. So Teresa talked about, if it's a superior that committed the act, then you don't want to go to your superior, obviously, to report. But additionally, there are uniformed victim advocates, which we'll talk about in a later slide. And there's also civilian victim advocates that a lot of civilians work with on the daily. So some patients are going to want to report to the uniform victim advocate because they understand the military culture, they understand the military resources, and they want a uniform victim advocate. But maybe they don't want a uniform victim advocate. They want a civilian victim advocate because they're worried about the confidentiality breaches. They're worried about different things that can be within the military culture. So they want someone who doesn't necessarily isn't involved in those aspects. The warrior culture, Teresa spoke about that as well. So you have to be strong. This can't happen to me. I'm going to look weak if I report. You know, this is also related to mental health issues that we see within the military as well. You know, recently, you know, people have been coming forward with mental health issues, and superior people have been coming forward and speaking out against that. And I hope that that continues to happen with sexual assault as well. And finally, another barrier is that nothing's going to come of their reporting. We all know in the news, everyone's seen where all the kits sit on the shelves and no one's doing anything about it. Well, in the military system, the same thing can happen with the actual report. So you report it to your chain of command, and maybe no one follows through with the correct protocols, no one steers you in the right direction, and it doesn't go where it needs to go, and the case just sort of falls through the cracks. And this can especially happen with junior personnel, and maybe there's a really unhealthy command climate and stuff is being covered up. And we just have to be really careful of where the patient's coming from and how those barriers can affect the whole aspect of the case. And the reason these are barriers is because they have happened and are happening. I pulled these barriers off of a survey that the military has done. So obviously they're occurring and still occurring. You know, recently the military has tried to correct these actions through education and change. They're trying to change the way that the cases are handled and who's involved from the beginning. As we know, the cases aren't black and white, and if alcohol is involved, it creates a whole nother can of worms. So they're working on how to navigate that, because the chain of command, like Teresa talked about, and then the CO is that normally the end all be all for issues within that command, but they're trying to pull sexual assault out of that. So we'll see kind of what happens in the future regarding barriers to reporting. Next slide, please. So we know the military loves acronyms. So the Department of Defense has the Sexual Assault Prevention and Response Office. They call it the DoD SAPRO. And this office isn't directly involved with forensic nurses in healthcare. They're mainly administrative, and they involve the response, but not directly related with healthcare. The big DoD office releases a prevention plan every year. A big initiative a couple years ago they spoke about was bystander intervention training. And that was, they called it like a full stop, where basically every command, every person had to say that they went through the bystander intervention training, and involved training those around potential victims, which could be anybody, to recognize that a situation was unhealthy. So if you're out somewhere, recognizing that this person is forcing drinks on this person, and try to bystander intervention. And they try to do less where you just kind of deter and distract, and then all the way to like maybe getting police involved. We're going to concentrate more on the response side, since that's more of the forensic nurse's main role. And like I said, the SAPRO office is not directly involved with healthcare related issues. So probably about 10 years ago, the DoD Safe Helpline merged with a contract through RAIN, and it's rain.org, and it's 2 N's. So it's the Rape, Abuse, Incest National Network. And so they can, through that organization, they can call, they can chat, and they can use the web for military specific resources. And that's a great line. They hand out cards. The SAPR, the local sexual assault prevention and response offices have cards, and at all the outreach events, and they have pins and everything with all the info on it. It's posted in the bathrooms. So there's a lot of ways for people to get assistance when they need it. So more acronyms. So from the response category, kind of the lead in that is called the SARC. So they're the sexual assault response coordinators, and they must be notified of any sexual assault that gets reported. We're going to go into the reporting options. So either way, a SARC is notified, and they handle the case. Every installation has that. They're confidential support, and they coordinate care for the victim of sexual assault through investigative and the recovery process. So all the way through. They're always notified, and they have strict confidentiality rules. If a patient doesn't report, they get an RRCN, it's a restricted case number. And so only the SARC has access to that database to be able to access that information. So the sexual assault prevention and response victim advocates, they call them SAPR VAs. There's a special DoD advocate certification that the SARCs provide to them, and they get certified. It's a week-long class, or maybe 2 weeks, but that they go through. And they go through from beginning to end on how to help the patient. I would speak at those regarding the medical aspect and how that their victim advocates could best help the forensic examiners. They provide one-on-one confidential support and education resources to the victims of sexual assault under the supervision of the SARC. So most of the time, a victim advocate will accompany the patient or be called, but sometimes the SARC is running the call schedule for that day. So you will get a SARC or a victim advocate if you reach out to these organizations for assistance. Additionally, this is something that's newer. The Special Victims Council or the Victims Legal Council. It depends what service you're in. Navy uses VLCs. So I think Army definitely uses the SVC. So they are special legal advice representation and assistance, and they help the patient to route the investigative justice process. And the communications with these attorneys are protected and can't be shared with anyone. So they're really helpful. I've used them before when I had a patient who was worried about the collateral offenses and they wanted legal consultation before they went through with the exam. So I had the VLC on the phone, and they talked to the patient and let them know kind of how things could potentially go either way. And then they decided to proceed with the exam. So the SARCs and the victim advocates are responsible for educating the patient on their reporting options. So the military has 2 different options, restricted or unrestricted. It isn't your job as the forensic nurse to educate them on the different types. You just need to know what they are and how they can affect the patient. So after this slide, I'm going to discuss the difference between reporting with unrestricted and restricted. This slide's just going to discuss how they enter the process and who gets notified. So if the patient gets to you through a military investigative organization or a civilian law enforcement, the SARC needs to be notified, and then the case is going to be unrestricted, which means there's going to be an investigation. So if it initially comes through the SARC, then it can be unrestricted or restricted. And then if a healthcare personnel is notified, then as a nurse, I would notify the SARC, and then it would go unrestricted or restricted. And usually how this would work when I worked in a clinic, if a patient came in and, they said they've been sexually assaulted, we would, full stop. Would you like an advocate? Would you like support? And most people in the military or who are within the military health system know that these terminologies. So we make sure that they, actually want an advocate. And I think maybe we had one time, Teresa, I remember at Portsmouth, where someone didn't want an advocate, but we get an advocate involved. And at that point, I'm working as just a regular nurse. So I wasn't working as a forensic nurse, so it wasn't my role to, dive into any of that. So I get the SARC and the advocate involved, and then the case can be unrestricted or restricted. So I'm sure you've noticed a little bit of a trend on who can receive restricted reports and who can receive unrestricted reports. So there's 2 report options. There's unrestricted and restricted. The terms can be confusing, and you just want to make sure you get your head around it, because some states refer to restricted reporting as non-reports or anonymous or Jane Doe. It was hard for me with the term non-report and unrestricted because they're actually opposite, but both had a word in front of the report part, so non or but they were actually the opposite of what they were. So with an unrestricted report, it's going to get investigated by a military or civilian law enforcement agency. The chain of command is going to be notified. However, when we tell them that the chain of command is going to be notified, it isn't that the full chart or the photos are going to be released to the commanding officer, and it's a need to know. So, if they're maybe lower on the totem pole and there's lots of leadership wickets there, it's not everyone within the chain of command. It's the CO, and it's need to know. So they're just going to know who was sexually assaulted, and basically now what's their role to make sure that this person gets the best care and the best help that they can. The CO is going to form more of an administrative role to make things happen for them. So there can be a military protective order. So kind of the same thing as a civilian restraining order. And then lastly, the patient can be offered an expedited transfer, which means that either them or the assailant, if they're maybe in the same command or the same base or close quarters, that they can be immediately transferred out of the command or the base to prevent further trauma to the patient. I could only imagine, having this happen to me and then having to go to a cafeteria and eat like down the table from the person that did this to me. And probably in the civilian world, you could avoid that type of situation more easily, but in the military, you just can't. So they offer expedited transfers, and this can even happen on ships as well. So with the restricted cases, so that means it's not going to get reported. It's not an investigation. As you can see, the only professionals that can accept a restricted report is the sexual assault response coordinator, the SARC, the SAPR victim advocate, and healthcare providers and support personnel. So if they notify their chain of command, then it's going to get investigated. With restricted, there's no investigation. Obviously, the police do not know about it. How you get a case number, like I said, is through the SARC, and they will generate a specific case number from their database that will then be written on the outside of the kit. So there's no specific command notification. The chain of command, so the CO, the commanding officer, will be notified that something happened within their command. They won't know who, they won't know who was involved or any details, but they do need to know, if the safety is an issue within their command. So say maybe a couple people were assaulted coming into the park, coming into work through the parking lot. Maybe he or she can put up more patrols, or maybe more lighting, or if it's happening in close-knit quarters on a ship, that could be detrimental, not only to other people that this could happen to, but to the actual operations of the ship, and it becomes a huge safety and national security issue. So that's why the chain of command is notified non-specifically. There's not going to be a military protective order because we don't know who, what, when, how. And there's no expedited transfer because the commanding officer can't expedite transfer somebody he doesn't know that it happened to. Let me see. So this slide is just the direct comparison of the two. And like I said, it isn't the responsibility of the examiner to educate the patient on this. This is the SARC and this victim advocate. And that's really why you want to get military victim advocate and support services involved. So always think, if a patient comes into your exam room, how is this flowing? How is this working? What if the patient comes alone? And they want an advocate from the military system. So do you know these contacts? Do you know who these people are? Usually the SARC is a very advertised position on the installation. So if you called anywhere on the base, maybe you couldn't get the SARC specifically, you could ask and they would give you the phone number. So it should be very easy to connect. All the SARCs that I've worked with have always wanted to improve the flow in the system and how it works from beginning to end for the patient. So with an unrestricted case, if the patient wants a military protective order expedited transfer, things are going to happen really quickly. And so events can be happening very quickly and it can be very overwhelming to the patient. So it's just important to know, if it's an unrestricted or restricted case, if it's unrestricted, things can move very quickly for the patient, and things might have already happened before they even entered the exam room. So just be aware of those dynamics. Next slide. So reporting options, even though there were lots of no's on the previous side, both offer many of the same care and recovery services. So with unrestricted and restricted, they're obviously going to get the sexual assault prevention and response support services through the SARC and through the victim advocates. And they also have counseling at these facilities. They can always receive healthcare and mental health care and the medical forensic exam. And they can get the spiritual support available, however that looks for the patient. And they can get the legal consultation that I talked about through those special representatives. And you can get access to those numbers through your local judge advocate organization on that military base. So you kind of just have a list of numbers of people to call and resources. SAPR services should kind of facilitate most of these things, but sometimes with the legal consultation, especially if they want it right before the exam or have questions about things with the exam and how that might reflect further, you can always contact them for the patient. Regarding healthcare and within the military health system, so when I worked in Fallon, I was a kind of a conduit for the civilian center SART that I worked at. So we made sure, that there was a one-stop shop when the patient entered the system. I know this is, most of the time in the civilian world, you just tell the patient to follow up with their civilian healthcare provider. A lot of people don't have them, but within the military, you always have the option to follow up with a provider, and they offer the services. So you can just put a bug in people's ear. It's not really your responsibility, but maybe you work at a military health clinic and you want to improve things. Maybe you're not going to do exams, but you can definitely make things easier for the patients. If someone calls, they immediately get transferred to one person who knows the system and knows what to do. They're not getting transferred around. Even our small clinic in Fallon, Nevada, we were able to offer, all the STI prophylactic medications, HIV prophylactic medications, immunizations, and they have labs. And usually that's all in one clinic, which is rare for civilian facilities. So plug into your local military base and see what services that they offer the patient, because you might be surprised about how much they can offer that people just aren't aware of. Next slide. So this is a new thing that I learned about while doing some research for this presentation. So restricted reporting now, they're actually offered some investigative options, where before the restricted report, the kit's done, the report's done, no one looks at it unless the patient wants it to move forward. Well, the patient now has an option, while staying restricted, the opportunity to confidentially provide information about alleged offenders and the incidents. So how this works, again, not the responsibility of the forensic nurse, but this information would get provided, and it's not at a local level that it's reviewed, it's at a really higher level that it's reviewed at. So basically it helps catch the serial offenders that are maybe moving around within the military organization. They're moving to different duty stations, they're deployed, and maybe something has happened at all of these places, but people are keeping it restricted and there's no way to connect the dots, and it just keeps happening and keeps happening. Well, now there's a way to connect the dots. So they can potentially match different incidents, reports, different things that are very similar, and then they can give the patient the option to take the report from a restricted case to an unrestricted case, and then they can participate in the military justice system. Okay, next slide. So lots of terminology that can be overwhelming. So the military several years ago, instead of using the term SANE, sexual assault nurse examiner, they moved to SAMFI, sexual assault medical forensic examiner. And this is because they are pulling from a bigger pool of medical professionals. So they're not just using nurses. So they're gonna be doctors, physician assistants, the independent duty corpsmen that Teresa talked about, that are specialized medics, we call them corpsmen, that can be in situations on ships or in locations where a patient can't be medevaced within a reasonable amount of time. So they're going to be trained how to do these exams. And then The kit, so the SAFE kit is what the military calls their examination kit, and these kits are processed at a joint lab in Delaware. Next slide, please. And some people might wonder, what type of kit do you use? It depends who has jurisdiction and or the agreement set forth with a local military organization. So the DoD SAFE kit can be very overwhelming. It has lots of paperwork. It's 14 pages. It looks very similar to California's kit and the paperwork. It has many pages with small writing. It can be overwhelming if it's not used frequently. So it kind of depends where you are, who has jurisdiction, all of this. When I worked in Nevada, if it was a Department of Defense patient, we did the DoD kit. So just kind of some things to think through. It's these conversations to have before the patient shows up in the exam room. And that way it's not a big issue on what kit do I use and when, especially for these facilities that maybe you don't see a DoD patient that often. Reach out to your local law enforcement or the military investigative organizations and see, what they prefer and what would be best for the patient. And then familiarize yourself with the paperwork and the instruction. The worst feeling for me is to be fumbling through the paperwork in front of the patient. I just feel like it breeds distrust and they think I don't know what I'm doing, even though I'm like, yes, I know what I'm doing. It's just this crazy paperwork with like 50 pages of instructions. So, just dive into this stuff before it becomes an issue. Next slide. So who pays for this exam? TRICARE pays for the exam. This is a covered benefit offered to anybody who is covered by TRICARE. So active duty and their families. Some veterans are covered by TRICARE. It sort of depends. You might not have an issue with billing if you work with a big hospital system, but it can be if you're with a smaller independent center, or maybe you don't do a lot of DoD cases and you're not sure about billing. TRICARE is tri-service. So no matter what service the patient is in, TRICARE will cover them. And next slide, please. TRICARE is split up into multiple regions. So there's East and West and overseas. Each of these regions is overseen by a healthcare insurance contractor who each have different claims processes. So it can be frustrating for you and me as the patient. When you move different locations, you have to enroll in TRICARE again. For the active duty, this is a little bit easier. You had this whole check-in process with medical and it's kind of an automatic enrollment. But maybe for family members, so they have to change their TRICARE region when they move and enroll. And each region is going to have a different claims process. I won't go into details, but you can go, you can type in TRICARE East, TRICARE West, TRICARE Overseas. They all have different websites. You can contact them directly. Again, just something to think through and figure out before you don't get paid timely and everyone gets frustrated. So again, TRICARE fully covers the forensic examination, and they have since 2006. It's been listed in their guide. So who takes custody of the kit? This is not something, again, directly that you have to figure out, but you might want to play out some scenarios in your head before it's 3 a.m. and no one knows who's going to take custody of the kit and you're exhausted. So sometimes this can be an issue. Most of the time, the local military investigative organization and local law enforcement have worked out agreements on who the assault happens to or where it occurs, on whether they're going to take the kit. I know sometimes the military organizations in an area are like, we are 100% taking any cases that occurs to a military member or their families, because they just want control over the investigative process, especially if they're PCS, so permanent change of station. So if they're moving frequently, it's harder to assist these people. But I've seen jurisdictional issues that come up, even if the assault happens on the base, because it's actually still local land, it's not federal land. So sometimes it gets complicated. So again, just some scenarios to place, to think out, if you have a local sexual assault response team, these are some questions that you could bring to the team, just hypotheticals, and see what can happen from there.
Okay, so this last section is just going to very quickly go over the military and civilian court, criminal court systems. I'm not a lawyer, so I'm just going to kind of breeze over some of the key areas. All right. So first you have the laws. You know, in the civil community, you have jurisdictional laws, state, federal, criminal laws. In the military, the active duty personnel are also responsible to follow what's called the Uniform Code of Military Justice. It's just the rules and regulations by which all active duty military personnel are expected to follow. And they include different laws such as dereliction of duty, conduct unbecoming, leave of absence without permission, or AWOL. So different things that don't necessarily fall into the jurisdictional issues, but active duty personnel are responsible for following not only the UCMJ, but also the local laws as well. And that's kind of when you get into jurisdictional issues and where's this case going to be tried. So you have criminal court system in the civil community, and then you have the court martial in the military community. So essentially, whether it's going to be a court martial or a criminal trial, there's a bunch of if-thens that go along with this. So the UCMJ only applies to active duty personnel. Therefore, if the defendant is an active duty person, the victim could be either be active duty or civilian, or even in foreign country, a foreigner, that they could be tried in the court martial process. If it was if the crime actually took place on base, then the military would have the first shot at jurisdiction. If it happened out in town or off base that falls under the local jurisdictions, then usually if it's two military personnel, a lot of the times the local jurisdiction who has first bite at the apple, they will kick it to the military and let the military deal with it. However, if you have a perpetrator who is civilian and the crime happened on base and the victim was military, then that would have to be tried in the local jurisdictional court system, because again, the UCMJ and the court martial is not for trying non-active duty persons. So it can get a little confusing. So if you work in areas where there's different jurisdictional issues, this is just something to be aware of so that you know what type of trial you may or may not be testifying in. Now, when it comes to a court martial, there's varying levels based upon the degree of criminality of the crimes for which a defendant is being tried. So sexual assault is one of the more severe. Domestic violence can be one of the more severe, depending on the level of injury sustained. And those usually go to a general court martial, which are reserved for the highest, most serious infractions. And they can end up in confinement, at Leavenworth, hard labor, reduction of pay, and then each level of the court martial has different punishments that can be awarded depending upon the severity. So it's like this, the misdemeanor and the felony level charges at the criminal level. Now, in the military, we do not have the equivalent of civil trials. So they're all felony level criminal cases that get tried in court martial. If a victim wanted to civilly sue a perpetrator of sexual assault or violence, then they would have to go to their local civil court system and file there, and then take care of that under that civil system. And then when it comes to the locations of the court martial, so in the civilian sector, the trials they take place where the crime was committed, because that's a jurisdiction that has oversight of those issues. At a court martial, the the active duty service member is tried at their location. So last case I did, the actual the sexual assault took place in Louisiana, but the Air Force member was then stationed in North Dakota when it went to trial. And so he was tried in Minot, North Dakota versus Louisiana. And it's all, the military court system is one big happy family. So a court martial that takes place in Minot or in a court martial that takes place in Sasebo, Japan, they will function the same way as they do, because they all fall under the UCMJ and the federal rules of evidence. Then when you talk about the trials, you can do a bench trial or a judge alone in both civil, criminal and civil, or military and civil cases. But the jury or the panel is a little different. So they can also choose a jury panel or a jury trial or a panel trial. And this is where, the jury is generally 12 peers from the local community, and the decisions have to be unanimous. In the military setting, the panels generally are officers. However, enlisted members can have panels that are comprised of somebody at their pay rank or higher, and officers. So that could be mixed between officer and enlisted. And there's no civilians that sit on the military jury or the panel. Also, the panel can be comprised of anywhere from 3 to 12 members. Usually the 7 to 9, 5 to 9 range is what they shoot for, and they do not have to have a unanimous decision. It's a majority decision, or usually 2/3 of the vote is what they require for an innocent or guilty. Testimony, it's the same. Your testimony as a fact or an expert witness in a court-martial trial or in a court-martial or a criminal trial in the civilian sector, it's the same purpose. You educate the jury, the judge, on what you did, what you saw, what you found, and then provide your expert opinion if you are qualified as an expert. So that really doesn't change. It's just kind of the processes. Defendant representation in the military system, in both systems, they can defend themselves if they choose. The military, they have appointed military JAGs, Judge Advocate Generals, they're the lawyers of the military. The ones appointed for a defendant as their defense counsel would be equivalent to the public defender's office in the civilian sector. And then in the military trial, they can choose to hire their own civil attorney as well. And so then they would have both the JAG, which would kind of step back and be not a forward role in the defense of that person, and then their civil attorney as well. In civil cases, JAG officers do not and cannot represent or defend active duty persons in civil criminal trials. So they would either hire their own or use the public defender. And then you have the convening authority. So the convening authority is the person with ultimate control over the member that is being tried for the alleged offenses. And this is really equivalent to the judge, but also not only the judge, but also the district attorney's office. So the convening authority, the commanding officer, the post commander, they will determine if the charges will go forward to a court martial. They can stop it there, they can move it forward. Just like the district attorney's office would determine if a case is going to go to trial or if it would be, dropped or needs more investigation. And then just as a judge can set aside a jury decision, that rarely happens, the convening authority of the defendant can also set aside the punishment and the decision rendered by either the judge or the jury in a military trial. They do function with a JAG counsel, so they don't make these decisions on their own. They're provided advice throughout the processes. But, as Andrea mentioned, they're trying to take away the sexual assault cases from the convening authority. And really, to put it into perspective, just kind of think if you work at a hospital, you're a nurse or you're a nurse manager, and the CEO of the hospital, if that was the person who determined your fate ultimately after a trial and accepted and dished out the punishment that the civilian jury decided, you know, your boss, your ultimate boss could decide to go with that or set it aside. That's what it's like. And you can see where there could be, you know, significant conflicts of interest. And there have been in the past, you know, especially when you get in the higher ranking officers that maybe know, have a good working relationship with the commanding officer. There could be the appearance of bias if the charges don't ever go to a court martial, or if the charges are dropped or lowered, or if the jury verdict is set aside by that convening authority. And so again, this can be a deterrent for people wanting to report sexual assault, but then also viewing the system as fair. So yes, there is a bill in, I believe it's in the Senate right now, I'm not exactly sure, but it's part of the larger bill that the military is using to combat sexual assault in the military, and taking these cases and other cases away from the convening authority to provide a level playing field and to make the system more fair and equitable to the victims is one of the top priorities of that. So I kind of see that moving forward. That actually concludes our presentation. I think we went over. I'm long-winded. So if there's any questions, also if there's any active duty or retired or reserve persons on, then you have a 20% membership discount for joining the Academy of Forensic Nursing. So I guess we'll do questions now, right?
So we'll move over to the Q&A, and I'm actually gonna also share our screen because we do want to make sure that you all are aware of the conference that'll be happening next week. So I'm going to switch over, okay?